Thanks. With regard to image processing, Carestream has an approach to image processing that takes across the entire portfolio. So if you were to put a DRX1 into an existing room today, and then let's say that 7-year-old room in 5 years is 12 years old, and you decide you want to replace it, at that point you may upgrade it to an evolution room, which is a fully integrated DR room using the same detectors. So in that case you have the same image processing and the same look. And the look is critically important, of course. You can spend a lot of time going back and forth between the modality and the radiologist, but we use a unique approach. We use something called the look selection tool. We go in with a disk of preloaded images of many different body parts and many different processing approaches, and sit down with the radiologist. It takes about 25 minutes to go through it. But by going through that, we then create an algorithm that we can plug into our software, which will then render all similar images with a similar look to the ones that were previously selected. It gives you a great starting point. It makes the back and forth with the doctors much quicker. So it gives you a new baseline, not the default baseline that the vendor selected, but it gives you the default baseline that your radiologist selected. So that makes things very quick. Then once you're in an evolution room or a full DR suite that has a DRX1 detector, how do you do things like stitching? Well, stitching works in the same way it does with a fixed detector room. Essentially, you shoot, move the detector, shoot, move the detector, shoot, move the detector, and then the system completely assembles the image automatically. So the detector moves automatically, the system assembles the image automatically, and because it knows the position of the image, it's fairly intelligent image processing to be able to stitch it with very few failures. On noise reduction, which was a question about dose management and noise reduction, Carestream has implemented noise reduction, which allows us to optimize not only our CR noise, but also DR noise. So in both the in-room situation or the DRX1 upgrade to an existing room, you would get a noise reduction algorithm. Another thing that we do is we use a special sensor array which has a 100% fill factor. And this really maximizes DQE relative to the pixel size. What 100% fill factor really means is if I have 100 micron by 100 micron pixel, actually I have 139 micron by 139 micron pixel, 100% of that pixel is sensitive to the light coming off of the scintillating screen. So the whole pixel is sensitive. What most DR detectors have is someplace between 65 and 80% of the pixel is sensitive to light coming off the screen, and the rest of the pixel area is used for readout electronics. So if the pixel is 139 microns in size on the TFT array, only 75% of it roughly is used for actual capture, and the rest is used for readout electronics. By making a multi-layered TFT array, you can maximize the size of the minimize the size of the pixel, make the smallest, sharpest pixels possible, and the best sensitivity. The last thing is multiscale frequency processing. The ability to do multiple structure size enhancement really allows you to control the noise, and that also allows you to optimize. EVP Plus is just such a processing algorithm, and it works. It allows us a great deal of flexibility in how we process any given type of exam. So those are the things that I think are going to have the biggest effect. And then long term, also to the dose question that was posed earlier, long term, not even that long term. Cesium iodide version of DRX1 is in the offing, so there'll be a tremendous improvement in DQE just by doing that on top of the 100% fill factor and the noise reduction.